Good morning, everyone. I'll be presenting on behalf of Medicine 4. Presenting the 43-year-old lady from Mizoram. She presented with her primary complaints of generalized body weakness for 1 year, stiffness in both upper and lower limbs for 1 year, and difficulty in speaking for the last 6 months. She was apparently well till 1 year back when she noticed weakness of the left upper limb, which was followed by her right upper limb, and lastly followed by her bilateral lower limbs, all of which developed over a period of 2 months. Her walking gradually became slow since last year. She was noted to take small steps by her relatives. The weakness was progressive, and she has noticed intermittent twitching of her thighs intermittently. She also had complaints of slurred speech and a nasal twang to her voice. There was no difficulty swallowing. She did not have any diurnal variation of the weakness. There was no sensory loss and no bladder or bowel incontinence. She did not have any vomiting, headache, altered sensorium, or memory loss. No seizures, and she did not have any other comorbidities and not in any regular medication. And she did not have any family history of any similar illnesses. On examination, her vital signs were stable. She was fully conscious oriented. There was no pallor, icterus, clubbing, lymphadenopathy, or edema. Her CVS, RS, and abdomen examination was normal. Coming to a CNS examination, her high mental functions were normal. She was conscious oriented. Her memory was intact. Her attention span was preserved. She had a pseudobulbar affect, AFFECT. She had a emotional lability. She had intermittent episodes of laughing. Her cranial nerve examination, the positive findings were that her jaw jerk was exaggerated, and she was also noted her tongue fasciculations. Motor examination showed a preserved bulk, but of her showed wasting of the first dorsal interossei and thenar muscles. She had spasticity of the bilateral lower limbs. Her upper limb power was diminished in the shoulders. It was 4/5 proximally and 2/5 distally. Finger drop was present, and her lower limb power was 4/5. Reflexes were exaggerated, and she had an ankle clonus. Her jaw jerk was exaggerated. She had a palmar mental reflex. She had ankle clonus and patellar clonus. Hoffman sign was present, and her plantar reflex were bilaterally withdrawn. There was no sensory loss. There was no cerebellar dysfunction. Gait was assisted, and she did not have any meningeal signs. So symptom complex she came as was that of a pure motor syndrome with asymmetric onset, painless, progressive weakness of both proximal and distal muscles, with UMN features of spasticity, hyperreflexia, and LMN features of fasciculations and severe muscle wasting. So differentials we considered for this were amyotrophic lateral sclerosis, multi-level cord myelopathy, and a craniovertebral junction anomalies. Her investigations showed her baseline investigations were normal. Her liver and renal function tests were normal. BBVS was negative. Her EMG showed a motor axonopathy with active denervation in cervical and bulbar myotomes with fasciculations and fibrillations noted. Her MRI spine did not show any cervical cord compression, and her neck height ratio was 10:1. So based on this, we made a diagnosis of amyotrophic lateral sclerosis in this patient. Just coming to the discussion, the diagnosis of ALS originally was based on the L-Escorial criteria, which was later modified in 2007 to the Awaji criteria. Later in 2018 was further simplified to the Gold Coast criteria. So the Awaji criteria actually included the presence of both element signs and the UMN signs. But in the Gold Coast criteria, this has been modified to either element signs or UMN signs only. And there has to be a progressive spread of signs within a region to other regions. And there has to be there has to be an exclusion of other possible causes based on EMG and neuroimaging. So again, the original L-Escorial criteria had classified ALS into either definite, probable, or possible. But the current 2018 Gold Coast criteria has classified, if the patient fits the above criteria, all of them are classified as probable ALS and the management as such. So coming to the management of ALS, currently there are very few drugs which are available. Riluzole is a drug of choice. Dose is 60 mg per day. The maximum benefit, it has been shown to have the maximum benefit in patients who have symptoms for less than 5 years, who do not have respiratory muscle involvement. But expert opinions also suggest that there is maybe a minimal benefit in patients even after they develop respiratory weakness. So it is given for all patients currently. Etraveone is a free radical scavenger which slows the disease progression. It has been maximally studied in patients who do not have respiratory weakness. But again, case reports do suggest some benefit in all patients. So riluzole, etraveone are given in all patients. Sodium phenylbutyrate, it helps in maintaining the mitochondrial integrity and delays the neuronal apoptosis. This is a newer drug which again is recommended for all patients. So coming to our patient, she was already started on riluzole elsewhere. We had started on etraveone after she had come here. We started on a first cycle, and she's planned for a total of 6 cycles. He also given her occupational therapy and physiotherapy. So learning points was to identify the symptom complex of motor neuron disease, neck height ratio measurement to exclude CP angle abnormalities, and treatment regimens for motor neuron disease.
Thank you, Andrew. Questions?
Can you slide on drug therapy of ALS?
Yes.
So what is the benefit from these drugs? So they have clinically meaningful in terms of quality or quantity of life?
No, sir. It delays the onset. Riluzole delays the onset of respiratory weakness by 6 months on average, but there's no difference in quality of life.
How expensive are these medicines?
Not sure.
Did we counsel the patient and family to questionable treatments?
They had actually originally come with the impression that there was a cure. We had counseled them that that would not be possible, that would only slow the progression.
There are no further questions. Thank you all for attending today's clinical meeting. And the best presentation goes to Medicine 1, A Hump of a Lung by Bobby.